All right, so Chapter 16, Nursing Assessment. We do have a 5-step nursing process. The first step is assessment, and that's just when we gather information about the patient's condition. It's not necessarily a head-to-toe assessment. We can also obtain a medical history during that assessment. We diagnose, our nursing diagnoses. We identify the patient's problems. We have plans. We set goals of care and desired outcomes and identify appropriate nursing actions. We have implementation, and that's actually where we perform those nursing actions that we identified earlier in the planning stage. And then we have evaluation, and that's when we determine if our goals have met those expected outcomes. Now, when differentiating data, we do have something called a cue, C-U-E, and then we have inference. Now, a cue is information that you obtain through the use of your senses. So an example would be someone guarding their stomach or their abdomen. That's a cue. An inference is your judgment of the cue. So if I saw someone holding their stomach, I would think their stomach was hurting. Okay? We do have subjective data and we have objective data. Subjective data is a patient's description or statement of their feelings or symptoms. I'm having chest pain. That could be an example of subjective data. We also have objective data, and that's what you or me as a nurse, that's what we observe. We can see that someone's sweating. We can see that someone's turning red. So what's the difference in subjective and objective?
Patient reports subjective, you see objective.
Good. So subjective is what the patient states, and objective is what we as healthcare professionals observe. Now, when we're obtaining information from a patient and they don't know or remember, can we use their family that's sitting next to them as a resource?
Yes.
Sure. What if they didn't have anyone with them? Could we call their physician's office? Could we call the pharmacy? Sure, we can do that. Now, in some places, you might have to get the patient to sign a waiver, and you have to fax that to the office of wherever you're getting the information. Don't forget about HIPAA. That's in place for our patients to have privacy and confidentiality regarding their records of health care. Okay? Now, when we interview our patient, we want to make sure that we are exhibiting courtesy, comfort, and connection. Okay? Also confirmation. So we have 5 C's. I'm sorry, 4. I can't count today. Courtesy is just us introducing ourselves and explaining what we do. If you'll notice in Skills Lab, you're always going to have to tell the patient who you are and explain why. You're going to do that in everyday life. You also want to address the patient in a respectable manner. You know, ask them, do you want to be called Mrs. Ewing, or do you want to be called Amber? And a lot of times you'll see people saying sweetie, baby, honey. Don't use those words if you can avoid it, okay? Comfort. So if our patient is being admitted for difficulty breathing, we still are going to have to get a health assessment on them, right? They come up from the ER. They might already be on some oxygen. What could we do to make that patient more comfortable while we're getting that information from them?
Set them on the bed.
Okay, so we could sit them up in an upright position. They have oxygen, so maybe we could get some humidified oxygen, get some water to bring in. Now, typically with patients that are having difficulty breathing, sometimes they might get dry of mouth really easily, especially if someone comes in with difficulty breathing, they're more than likely going to have a face mask on. So if they're allowed to drink, couldn't we get them something to drink, ask them what their favorite beverage is? Or if they were in NPO status, we could also do the mouth swabs to help keep them comfortable, okay? Frail little old ladies, they're going to be complaining that they're always cold. So could we get them a heated blanket? Yeah, probably. Remember to close the door, because sometimes patients might, you know, maybe they've had a bowel resection, they have a colostomy. Well, they don't want to tell you that with the door open and their preacher standing outside, you know. So make sure you close the door and have some privacy there. Now, it's important to try and connect with your patients during that assessment. Try to avoid relating yourself to them. A lot of the times if they tell you a story, well, this happened to me in 1975, you know, you think, oh, well, that happened to my grandma, you know. Don't really talk about that. You're there for them, okay? If you need to, a lot of the times we're at the computer. The computers are on the wall in most facilities and our back's turned to the patient. Try and swing that computer around if you can't get it that way to where you're looking at the patient, because a lot of patients have hearing problems and they're not going to be able to watch our lips if our back's turned to them, right? If you can, if you think you have time, just write on a piece of pen or write on a piece of paper, sit down next to them, get their information, go back in later and put it into the computer, okay? As an entry-level nurse, you're not going to have just a 12-hour shift. It's going to be a lot longer. So it's okay to write it on paper and go back and enter it in later, because 9 times out of 10, you're going to be at work a lot later than you expected, okay? This is not a 7 o'clock, I'm ready to go home, okay? Also, whenever you're talking to the patient, make sure that if they did say something but they're not for sure why they had that done or what happened to them, make sure that you're asking them, you know, well, would you like me to discuss this with you? I know a little bit about the topic. I can tell you a little bit about it. Also, you want to ask open-ended questions. You want to say, you know, how are you doing today? Can you tell me things that you would like to discuss today? Not closed-ended questions. Open-ended questions are good, especially a lot of times when people come in, you say, do you have any allergies? And they say no, and you're like, okay, great. And then you're past the allergy page, you're halfway into your assessment, and they're like, oh, well, when I eat tomatoes, I turn red, you know. So it's a good idea to say, you know, ask them, tell me about any bad reactions that you've had to any medications or food, not just do you have allergies. Think of ways to get their brain working, because if you ask them about a bad reaction, they're going to remember that bad reaction more so than do you have an allergy. Okay. Now, back channeling is a term that your book talks about, and that's used when you're actively listening to a conversation. You know, back channeling are terms like keep going, all right, you know, just those small little cues. And those are good. Usually that helps someone know that, hey, they really care about me, they're listening to me, okay? Now, in my book, it's page 219. I'm not sure which page it is in your book. I'll try to get the old one and find out for you guys for next lecture. But it does go over an acronym, PQRST. PQRST. Now, this acronym is useful when you're gathering data, especially if a patient presents with a certain illness. P stands for provokes. So you want to know what causes the symptom, what makes it better. Q stands for quality. You can ask them, you know, if they come in with chest pain, what does your chest pain feel like? How does, you know, what if they come in with an injured leg? Well, how does your leg feel? Is it heavy? Is the pain sharp? Radiate. Does the pain stay in one place? Does it move? S is for severity. You want to know on a scale of 0 to 10 how bad that pain is to them. T is for time. So when did that symptom occur? How long does it last? What aggravates it? What alleviates it?
Can you repeat what P was?
Absolutely. P is provokes. So what causes it? Q is quality. So how does it feel? R is radiate. S is severity. Can you tell me on a scale of 0 to 10? And T is time. When did it occur? For how long?